Our next session is SILS in GI surgery. Dr. Ajay Sharma.
Morning, everybody. First of all, I'd like to thank Dr. Rajneesh and Dr. Mandal to give me this opportunity to come and have a session over here. How did it all start for SILS? Actually, Dr. Rajneesh called me कि SILS करते हो ना? मैंने कहा सर आजकल नहीं कर रहे. Then he asked me पहले का है? मैंने कहा हाँ सर है. Can you suggest somebody who can talk on SILS? I told sir बहुत सारे लोग अब पीछे हट चुके हैं. And then he told ठीक है. Then I think you should do justification to this topic. And more justification came yesterday when we were in the bile injury session. How many of us were in the bile injury session yesterday? Can you raise your hands? Okay. So we have one evidence who can, okay, two evidences who can support when I'll come to the end of this session today. So now SILS was promoted a long time back. Let me first introduce, I'm coming from Mahatma Gandhi Medical College. I am professor and head at Mahatma Gandhi Medical College, Jaipur. So, I put this in second slide because SILS is a controversial topic, need a discussion, need a lot of endpoints to it. And just going initially before GI, what is SILS? It is one of the minimal invasive procedures. Audience, all are doing a laparoscopic procedure, I think. Can you raise your hands? Who are doing all laparoscopic? Majority laparoscopic procedures. Okay, how many are doing SILS? No one. Okay, 1, 2, 3. Good. So we have 3 people who will be in active discussion on proponents of SIL. 1997, when it was a discussion, then why should we have more number of ports? Can we have decrease in the number of ports? And when I was doing my MCH, I was also thinking, why do we need 4 ports? Can we decrease the number of ports? And that was going on in that era when 2002, 2003. Basic idea was to decrease the number of incisions from a large incision to multiple small incisions laparoscopic, multiple small incisions to a single incision. What is the biggest drawback of SILS? We are all going from the same hole. The camera is going, your instruments are going. So that classical triangulation that we say, that they should make an angle of 45 degrees. The camera should be at the center. You should be able to view from various sides. Is difficult, definitely in SILS. Why is it being accepted? Can anybody suggest why SILS is being so much accepted in the society now? Not now, it was being accepted. Because patients demand it. It is not the surgeon's demand. It is the patient who is demanding. These are all synonyms which have been used. SILS, some are company-induced name. SILS was actually given by Covidian. Notus is another company, and now Opus has come with one-port umbilical surgical instrument has come from Johnson. So there are other companies which have branded this. So SILS was actually a name given by Covidian because they were making all these instruments. But I think we can use either the names single-port incision or whatever it is. So it is ports, instruments and scopes that is the most important to be discussed. We started SILS because it was difficult to get that instrument, to get that port. So we made a single incision, 3 holes into it, and putting 3 5mm ports and 2 5mm, 1 10mm port, and through that we would put a camera. That's how we started SILS procedure. Advantage was low cost, and from the same incision you can put all the 3 instruments. We tried gloves also subsequently so that to prevent the air leak and all. But it is a very blind dissection, very difficult, and then subsequently you make a single large incision at the end. And this is a R port, which if you can see, this has one large opening to have a 10 mm or a 12 mm instrument or a stapler which can pass through that, and 2 5 mm ports and one separate camera port. The thing is, the problem was it was having a persistent leak, and it has lots of smoke into it. Then came gel point. Gel point was having a gel material over it through which the instruments could be passed. The disadvantage was the instruments were gradually, they were not holding into it, they were slipping out of it. Though it was relatively better as compared to what the other port was. Then came the air seal, which is having no ports, no openings into it, and then the instrument can just pass into it and blindly, and then subsequently you can make the orientation. But the definitely organization was very difficult with this. Now coming to instruments, it can be a straight instrument, a bent instrument, and articulating instruments. A simple laparoscopic instrument you can use, meaning to say you are using a right hand for the left instrument, left hand for the right side instrument, which you use routinely for laparoscopic. A laparoscopic instrument, if you say for gallbladder, with the right hand you do a Callet's triangle dissection, and left hand you retract the neck of the gallbladder. In this one you do it reverse way. From the right hand you are retracting the neck of the gallbladder because you are angulating it in the opposite direction, and from the left hand you are doing the dissection at the Callet's triangle. So lack of triangulation, lot of crossing of the instruments. When the instruments cross, the knotting, suturing becomes almost impossible, and definitely they will keep on hitting each other, and they will keep on hitting the camera port as well, and there is a lot of staggering. Then came some of the companies that started manufacturing the pre-bent instruments so as to make it easy, and believe me, this has made the things more difficult because it was very difficult to learn to use this pre-bent organized instruments, though it was cheaper as compared to the other instruments which have been developed by the Covidian. And these are the articulating instruments which were made initially by Covidian. You have a control in the hand so that it can bend at the tip, bend at the angle, both the ways. But definitely making this instrument usable was difficult, has a long learning curve, and a low strength of retraction. Same thing came for the endostress device, and that was for because suturing was being used in this. And then came the SILS scope, which is Olympus has installed this 30-degree telescope, which can be used. Mainly, these all things were developed for SILS, not for a routine surgery. These are not for a routine laparoscopic surgery which were developed. Development came because of SILS and being utilized more in now a routine laparoscopic surgery. This scope is very good if somebody wants to use in a routine laparoscopic surgical procedure. What is the advantage? Definitely osmosis. Biggest advantage is ease of tissue retrieval. The gallbladder which you keep on hitting at the umbilical port or the epigastric port becomes very easy because now you have a wide opening from which it can come. And pain, some say that it is less pain, but there's still a controversial issue. The statistics say that there is less pain. You can do two procedures, one at the upper end and one at the, suppose you want to do an ovary and a cholecystectomy, you can do from the same things. This is one controversy which is, biggest advantage is the patient acceptance. That is the biggest advantage of it. And no standardization equipment. Now these are the big areas of problems: ergonomics, learning curve, high incidence of surgical site infections, large incidence of incisional hernia, cannot be used for advanced surgeries, difficult analysis of the procedure, and very high advanced engineering which is required. I'm just showing a small video that laparoscopic appendectomy by a SILS procedure, putting a SILS port. This is by a Covidian port that has come. So you can do a simple, that is a simple. You can see the appendix, it looks less of inflamed appendix, just pain which was there. And then if the same appendix was inflamed, having a collection, having adhesions onto it, I think SILS would have been impossible in that scenario. Second thing, you are having an instrument which you can see articulating, pulling it onto the appendix up, and with a single hand you are trying to reposition your suture. This repositioning can put it more into the cecum, can leave a long stump of the appendix because you're not able to organize it because you're doing it with a single hand. So definitely it is not that easy to do it with a SILS procedure. As I told, the biggest, now harmonic can be passed from a 5 mm port, and they are all malleable ports, so it can be increased to the size. You can pass a stapler, that is an advantage. But definitely getting angulation onto it, you don't have an angulated harmonic, you don't have an angulated ligashore. So this last step is the biggest, coolest step in SILS, that is getting it out from the epigastric port, from the same port. For cholecystectomy, since we have to retract the fundus, we have to retract the neck of the gallbladder, we have many techniques that fundus can be sutured. The neck, you can have a puppetry like of retraction in which you can retract it onto the either side. Then there have been devised an endo grab hook, that is, you have a small hook which grabs the neck of the gallbladder. And just a small video for the same. Now you see, even with the experienced person, it's the hand is staggering. It is not fixed as compared to a laparoscopic routine procedure. This is the sutures that have been passed at the neck so as to retract it on the other side. You see, this is the simplest gallbladder that I think everybody will agree. But even this dissection is difficult. You are identifying it with the same instrument, difficult to orient yourself with just doing it with a hook, getting it with other instruments becomes slightly more difficult, but definitely at the end you could achieve a good safety. You could see the liver and then subsequently applying the clips over it. So some studies, SILS has optimal exposure, suboptimal exposure, technique has been shown to be slightly longer duration. Prospective double-blinded trial found significant differences in pain score, and definitely there are much disadvantages which have been shown. A simple ileostomy, this can be done with a SILS port, which is, I think for this, I would say that this is the easier method. You don't need to have a classical port which we are using over here. You see the liver metastasis from that, and then you identify a simple, the terminal ileal loop, and then take it out from the same hole which you are planning to make a stoma. This is one area which I think it has a slight more advantage as compared to any other procedure in the abdominal surgery. You take out the loop, just put a Babcock, and then just take out the loop and you can make a stoma. Right hemicolectomy have been tried. The trials demonstrate SILS for colorectal cancer can be used safely but has no clear-cut advantage. So for an advanced surgery, SILS is not more advantageous. We have used bariatric surgery also. The only thing is liver retraction has to be adequate, because with SILS by definition should not have any other opening, should not have any other port. So some people have used 3 mm ports to retract the gallbladder. Some people have used the sutures to retract the left lobe of liver. Some say that just retracting the left lobe of liver can be done by a single drain site which you will use in sleeve gastrectomy. But they have all been tried, and people have used SILS for that. Other procedures which we have done long back have been fundoplication, cyst, hydrated, spleen we have done, and small bowel resection, it's relatively easy. Ileostomy is standard. I think that is one of the most advantageous procedures. Colostomy, LAR, and incisional hernias, it is again, you make for a small umbilical hernia, you make a large defect on the right side, putting the 3 ports from the same, you're making one defect, you close and you leave a second defect. So that is for the incisional hernias and umbilical hernias. This is the recent advances that magnetic anchoring guidance system, but it is no longer being used and it is not propagated now. So conclusion is that to date, evidence we have suggested that the SILS procedure are comparable to the standard laparoscopic techniques, at least for the uncomplicated biliary or enteric pathologies, but increasing experience. I will not use this conclusion. Though my next slide is thanks, I did not want to write it. Now, though my time is up, I'd like to take 5 seconds for that let me tell very clearly, I stopped doing SILS in 2010 because I was uncomfortable. I felt it is wrong. Fortunately, I did not have any complication, but I know with SILS, they are more likely to have more complications. I think in coming years, SILS will have to be banned, and especially with the robotic being in practice. I don't suggest the newer generation to go into SILS. It is easier to do a laparoscopic procedure, to have better instrument placement and better surgery, rather than trying to satisfy your patient to give a smaller port. Though I am not absolutely against it, that some people who have been doing it, they may do it because in their hands it is safe. But for a standard, I think I would not communicate. So I think what is the session name today for this morning session? It is? Odd one. So this is the biggest odd one. So SILS is the biggest odd one, which has to be, we have to go out of SILS now. So I think I welcome if any questions can be answered. Yes, please go. So we have 2 senior people in back and ready.
Good morning. Bij from Delhi.
Yes, Dr. Bij.
I loved your very balanced talk. And since you inquired in the morning, anybody doing it. So I was the first one to publish it in surgical endoscopy in 2008, and I do it only for breast. I called it SPA, single port access for endoscopic breast surgery, transaxillary. And then at Gangaram, we had articulating instruments right from the beginning, so we did all procedures. But I agree with you, it should not be done. It should not be done, especially because I don't use any energy in cholecystectomies, which is also published in surgical endoscopy. So it was really challenging, but we could do it. It should not be done. It's nothing. So I even wrote an article, invited editorial in surgical endoscopy about acronyms. I called it SILS, single incision, DILS, double incision, THRILS, 3 incisions, and FRILS. So I said stick with FRILS. So thank you very much. But it never happened to me that ileostomy is SILS. This is what we routinely do. If indication is there for end colostomy or ileostomy, then
I think at the end that is the only procedure which I think is
but
advantageous.
I don't think we can call it SILS.
No, I will not call it SILS or some
by
other
that-
name,
by
but
that
it has an
definition-
advantage. It has definitely an advantage
By
over
that definition, conventional surgery is single incision surgery.
Yes.
Another editorial in Indian Journal of Surgery, which I think I published in 2012 or 13. So I said conventional surgery is single incision. So there is no need for laparoscopy to come in a way. So thank you very much.
Yes.
Just to make a comment,
Yes, sir.
SILS is, I wouldn't say that it should be abandoned. It is coming back with the advent of single port robotics, right? So if you see, Da Vinci has come up. It's not available in our country, but I have, attended sessions and I've done workshops in that. And single port Da Vinci is, in fact, you have 3 single port robotic platforms which are coming up. One is from Medtronics, one is Colobris, that is from the Texas-based company. They're all single port, but the most popular now, especially in the US, is single port Da Vinci, SP XI system. So it's actually used for abdominal surgeries as well as for endoluminal surgeries.
I think
so that is something which
yes.
Has to be.
My last sentence, I think you have not taken that sentence completely, because I told with robotic and with the multiport laparoscopic surgery, still should come down. So I said robotic is the future. So with robotic, I know that there can be many manipulations which can be done much more easily.
So you have much higher degrees of freedom, so you don't have problems of articulation.
So therefore robotic I excluded.
Yeah. So even that limited space of a lumen, you can actually use that.
Yes, I agree.
I just wanted to add that.
Yes. Thank you.
I was about to say that, but I forgot. But abandoning SILS was not the answer.
Then excluding robotic, I would
No,
say.
robot is also a tool.
Yes.
They say a fool with a tool is still a fool. So laparoscopy or robot, both are tools.
Yes, sir.
So we have to replicate the wisdom of conventional surgery everywhere.
Thank you, sir. Thank you. I think we'll stop the discussion here in the want of time.
Okay.
I think the message which should go out is we need to have a safe surgery. So approaches will keep on changing with time. So things are changing, approaches will keep on changing, but the bottom line is a safe surgery for the patient.